Institute today. So I'm Andrew Dhawan. I'm one of the neuro-oncologists at the Cleveland Clinic in Ohio, and this workshop will be with Professor Heiko Enderling of the MD Anderson Cancer Center. And so we are presenting the project on neoadjuvant stereotactic radiotherapy versus upfront surgery for brain metastases. So I'll break that down for you. I have no disclosures. Oh, sorry, the titles are cut off. But anyways, brain mets are a major clinical problem. Okay, these are when cancer decides to leave whatever organ it has started in and go through the blood system and land somewhere in the brain. And it's a very harsh microenvironment in the brain. The cells proliferate, survive, create their own little niche. And the prevalence of various subtypes of cancer that go to the brain roughly follow the distribution of cancer in the general population, roughly, because there is some tropism for various tumor types to reach the brain. When cancer reaches the brain, we often think it's just the tip of the iceberg, and we'll get more into why we think that. But just some statistics. So, this affects over 170,000 people in the US each year. This is actually a very old statistic, so it's probably closer to 250K. And these are 10 times more common than primary brain tumors and incredibly debilitating. And actually, their incidence is increasing in the general population because patients with cancer now live longer. And they live longer because the systemic treatments are better, right? Our chemotherapies, our immunotherapies, our targeted therapies that all of you have heard about, and maybe even some oncolytic viruses, are actually better than they have been in the last 20 years. But many of these therapies don't get to the brain. And so that's becoming quickly a very common sanctuary site for tumor cells. And this median survival statistic is 4 to 6 months. That's probably very old. We think of it more in the order of a year now, but it's certainly quite variable. So, all right. So how should brain metastases be treated? I've just told you that the chemotherapies we give often don't get to the brain. Some of them do. But if you have a large brain metastasis, kind of like, I'll show you this picture here, like some big, big brain metastasis like this, and it's causing a lot of symptoms, you could make the argument to treat it surgically, okay? But if you treat just one surgically, what about all the other ones? You can't possibly operate on every single tiny spot, and that's where the tip of the iceberg phenomenon comes in. And so there's this question of, well, if you see one singular large lesion, typically one would operate. And so the neurosurgeon will operate and take out the metastasis. And then the question is, well, what do you do after? And observational studies have shown us that actually the cancer tends to come back even after you cut it out, because cancer cells spill out while the surgery is happening, and it's not a perfect system. So what do we do after? We radiate. So we offer radiation. And this is pretty interesting because this is actually a mode of radiation that's a little bit novel and atypical compared to traditional radiation. So this is what's called stereotactic radiosurgery, which is essentially many small beams of radiation combine and focus on one particular region of brain, i.e. the surgical bed, and radiate all of the cancer cells there. Now, this is different than traditional radiation, which is given in many separate fractions via a different type of machine. And those are at lower doses. This is a very high dose comparatively, and it's typically given in 1 to 5 sessions only. And it's highly targeted because the risk of hitting normal brain is that you cause damage to the normal brain, in which people will be incredibly symptomatic and won't do well overall. So that raised the question, well, if you're going to treat with radiation anyways, why not do the radiation first, kind of sanitize the tumor bed, and then do the surgery? And there's some advantage to that. And so the key question that we're going to try to address through this workshop is this question of scheduling. Should you do radiation before surgery or surgery before radiation? And we're really talking about the case where you have a singular large metastasis, because that's really where this clinical question comes up. And so the concern I was referring to with the surgical approach, it's a little bit hard to see here, but essentially, in this case, this tumor was operated on, and a couple months later, the cancer cells had spilled out during the surgery and now coat the brain. And you see the same thing here with kind of more distant metastasis. We know that these probably, like this lesion probably wasn't there at the time of this guy being operated on and because of its location around the brain, and because we've seen this pattern so many times. So because of that, we really think it is the surgery that's causing these problems. So what are the advantages and disadvantages that we know about for scheduling radiation before or after the surgery? So the advantages, that maybe it improves the local control and it sterilizes the surgical bed. Maybe there's less side effects. And the part that I think is the most interesting, that I think a mathematician can help us with, is this issue of systemic control. Because what happens when you radiate the tumor bed is cancer cells die. And as cancer cells die, the immune system steps in, starts to recognize those antigens as cancer antigens, and you're training your immune system to recognize cancer cells. So there's this immunogenic effect of radiation that we know happens in patients. The question is, does it happen in stereotactic radiosurgery? And I think that the jury is open on that. But it's a fascinating thing to ask. And so that's kind of the idea. And so this immune response is actually crucial and maybe can be harnessed to really kind of make a difference overall in these patients, as in perhaps radiation itself can be an immune sensitizer. The question is also in timing, because how long do you wait after having done this radiation? Because what we do clinically is that you radiate, wait a day, and then roll the patient into the operating room to take out that big thing. But perhaps you should wait some time after doing the radiation. But how long should you wait? How long is appropriate? And why don't we get the same immune response by doing post-op radiation? Even because there are still cancer cells there. So why don't we get that? And could that be another strategy? So these are kind of the major questions, I think. The way I'm approaching this, I think, with Dr. Enderling is really to consider radioimmune modeling. And so he's got a really lovely paper here where he's got a radiation model with an immune model. And I found this as well while I was kind of searching for this. And both of these papers have very robust kind of DE models that I think we can use to start answering this question. The difference is really in how the radiation is modeled and the fact that the brain is quite a unique microenvironment. I think one thing that we have to also consider is, because this is very high dose radiation, the issue of complication probability, so something called NTCP for the normal brain surrounding the radiation field. I think agent-based models could also be a really reasonable approach. And then, of course, there are clinical trials ongoing for this exact strategy. Those won't finish for at least a few more years. So maybe there's some database mining that can be done. And perhaps there's something interesting about the immune signaling networks of biochemicals in the brain that can be studied with regards to this. So I think that's my last slide. But yeah, so that's all I've got. But happy to work with anyone interested in this topic, and we can speak more, of course, about the approaches when we actually start digging into this. But thank you. Take questions.